Yeah, good morning. Good morning, everybody, and welcome to Grand Rounds. I'm just super excited to have Dr. Sarah Taylor here for Grand Rounds. Normally, we have a neonatal nutrition conference in October and invite one of the speakers at that conference to be our visiting professor, and that would have been Dr. Taylor, except that, of course, we're all home and Zooming in. But she graciously agreed to give Grand Rounds today, and we're excited about that. Sarah is a national leader in the science of lactation and in neonatal nutrition. She's part of this new guard of nutrition researchers, neonatal nutrition researchers that includes our own Sarah Rammel and Mandy Balford and people like that. And it's just exciting to see them carry this the nutrition agenda forward. Sarah did her medical training at the University of Miami, and then she went to the Medical University of South Carolina, which is where I thought she was going to stay. She worked there both in vitamin D and human lactation with people like Carol Wagner. But in 2018, she got a wonderful opportunity to move to Yale and is now an associate professor in the Department of Pediatrics there. She's been funded by NIH to study both vitamin D metabolism, which you know is an issue in breastfed kids, as well as human milk, and specifically how human milk can be used in the newborn intensive care unit. She reviews for just about every important journal out there in nutrition, and we are just super excited to hear about the science of human milk and lactation. So, Dr. Taylor, welcome to snowy Minnesota.
Well, thank you, Dr. Georgia. I do wish I was there with you, though, until I heard about the 6 inches of snow, and that might have been a lot for me. But I'm very excited to be with all of you all virtually. Greatly appreciate this invitation, and I'm excited to talk about this topic. I do have some disclosures there, some consulting, as well as some grant support. So colostrum, human milk. Uh, I'll start with an area that helped me as I was starting a milk bank in South Carolina. We were in a very small town in the upstate part of South Carolina, and we were trying to start a milk depot where women could come and drop off their milk to then come to the milk bank for donation. And this milk depot was going to be in an agricultural center because that was where most people were coming to in this county. And we were talking to the men there about how this milk was going to be coming in, and I was very nervous about how well this was going to be accepted, and had one of the farmers said to me, well, you know, if my pigs don't get mom's colostrum, they die. And as soon as he said that, everything clicked, and he was ready to be part of our milk depot. So it's really interesting where you can find your different milk champions, including in rural South Carolina. We're fortunate, though, that humans do not die if they don't receive colostrum. So we are different from other mammals and that our babies can be formula fed. And there are some excellent formula options that are available, especially in the United States and North America and other countries. Of course, they're not available worldwide. So we are fortunate that we're not a population that has to have colostrum to survive. But we do have a subset of the population that does have an increased mortality risk if they do not receive mother's milk, and that is our very low birth weight babies. So even though we may not be the same as pigs and needing the colostrum, we still get a significant benefit from human milk, and especially for our very low birth weight babies. Human milk, one reason that we have this benefit for the very low birth weight babies is they're still supposed to be a fetus. And human milk is this natural continuum from amniotic fluid. They are very similar, which makes sense in evolution, that if you have something that works well for the fetus, might as well have something that's very similar to it there for the newborn, for the infant. And so they continue, there's a phase of gut maturation that's occurring from amniotic fluid exposure on until human milk exposure. And for the infant, so once you're born, that human milk is going to relate to the gut maturation, the gut development through intestinal wall development. There's critical that we're just learning more and more about this inflammatory balance in the gut. If you think of how many immune diseases and inflammatory diseases involve the gut. It's critical both for infants as well as on through life to maintain this inflammatory balance. And of course, then the microbes that are there are really a part of that and how they interact also with human milk. And so when you think about what is going into that newborn gut, the two options we have for the most part are infant formula, and you see it there on the left, and it's a fluid, and then human milk, where there's cells and there's these fat globules that are there, and there are just an overwhelming number of macronutrients, so definitely the carbohydrates, the protein, and the lipids, but then also cytokines and hormones and cells, as I mentioned, immunoglobulins. All of these are critical to the development of the infant, both the gut and then the rest of the body also. And if that human milk was just, or all of those components were just mixed together, they would not do everything they were supposed to do in the human body. So for example, we have a lot of enzymes in human milk. If we don't separate the enzymes from the components on which they are going to catalyze a reaction, then of course there would be no reason to have the enzymes there. So it's critical that we have these compartments of human milk that include the water phase there, the cells, but then also these micelles that are kind of in the colloid, and then these fat globules that are full of cholesterol and phospholipids. And the other thing that is so interesting with human milk, so not just that it's compartmentalized, but really every bit of substance in that milk does something. And in fact, a lot of times it does more than one thing. So for example, when we think of cells, cells need to have a membrane. That makes perfect sense. But in the milk fat globules there in the human milk, that membrane, it has functional components. So the sphingolipids that are in that membrane and the cholesterol in that membrane have been shown to be involved in brain development. And so really it's very compact, so that every component of that milk is doing something to mature, to develop that infant. Another example of a multifunctional milk component is lactoferrin. I picked lactoferrin to talk to you about because I think that there might be some iron research that might be done there in Minnesota, something about iron being important for the brain. And so lactoferrin is important. It's part of the human milk compositions that's there to help with iron absorption. And we've known for decades that lactoferrin appeared to help with infection. And we thought that it did so to decrease infection by removing the unbound iron, so it wouldn't be there for bacteria-like iron, for the bacteria to thrive on iron. So that's really what we thought lactoferrin did. What we've learned since is that it's not just through its role in interacting with iron where it decreases infection. Lactoferrin can directly stimulate macrophage phagocytosis. It directly inhibits viruses, including HIV, and is probably one of the important components of human milk, why an infant who is exclusively breastfed by a mother who's HIV positive will not be infected with HIV, which is really an incredible finding. Whereas if the infant is formula fed and human milk fed, then they have a high risk of developing HIV. And then it's not just the lactoferrin. When lactoferrin is partially digested and into lactoferricin B, that also has a broad antibacterial activity. So these multifunctions of so many components of human milk is why it can be both a nutrition as well as developing organs and also helping us to fight infection. A lot of cells in human milk. Initially, there's 1 billion leukocytes per liter. Now, this is in the colostrum, which is, babies are just taking a little bit, but still, this kind of concentration of leukocytes is overwhelming. So they're hypofunctional activity at this time so that they're not harmful to the infant. And then as lactation goes on, it's more epithelial cells that are there. There's less of this immune boost that needs to be given to the infant. The milk is also involved in maturing the intestinal wall. So some work that we did in South Carolina, where we showed in preterm babies that the more human milk, more mother's milk that the infant received, the less permeability. So the more the maturity of the gut was more similar to an adult gut than to, whereas the formula fed infants had very leaky guts, which would go along with a disease state. Stem cells in human milk, we're still figuring out why they are there and what they do, and numerous growth factors involved in maturing the intestinal wall. And then if you could remember, when you're developing, you need to be proliferating and having cellular development, but you also have to have programmed cell death. Apoptosis is critical in development, and there are also components of human milk, specifically hamlet, which is a product from lactoalbumin that is involved in apoptosis and has been used to treat some cancers because of its role in killing cells. Human milk oligosaccharides. This is a big topic you're going to see. If you haven't heard of human milk oligosaccharides, you will. This is a growing area of understanding. Now, we've known about human milk oligosaccharides for a long time. If you see there, back in 1954, the fetus factor was described. And if you think way back to, for some of us, to medical school and such, I remember learning about the fetus factor, not 1954, but we still were discussing it, that there was this factor in human milk that appeared to affect which bacteria were there in the intestine. So it's appeared to specifically grow and help the bifidobacterium to proliferate. So there was this positive relationship between this factor and bifidobacterium. Since then, we've realized that this is the third most abundant component in human milk, and it's not digestible. It is not there for nutrition. It is there specifically to help with establishing that microbiome, protecting against infection, and also protecting against inflammation. And just to show you a little bit how that works, this is a great diagram from Misty Good's lab in St. Louis, and specifically just looking at the left, since this is, I'm talking about human milk oligosaccharides and not necrotizing enterocolitis in general, but looking over to the left, you see these oligosaccharides. They do bind with some bacteria there. There are decoys, so the bacteria will think that they're attaching to the epithelium, but they're not. They're actually attaching to these HMOs, and then would be excreted. Then, as I mentioned, that these human milk oligosaccharides, or HMOs, also are feeding and proliferating the bifidobacterium, but they don't stop there. Even though they're not digested, they are absorbed, and then inside the bloodstream, in the circulation, they reduce the leukocyte rolling and infiltration, they decrease inflammatory markers, and then also have a role in decreasing necrotizing enterocolitis. So again, third most abundant component is not a nutritional factor, but instead an immune functioning and anti-inflammatory factor. So that's just a taste of what the science of human milk composition. Let's talk a little bit about the physiology of milk production. So it is very hormonally regulated. Hormones are crucial to the ability for a woman to produce human milk. And it's starting up there in those areas of the brain that, of course, are critical for hormonal production, which is the hypothalamus, and then both the pituitary gland, and then also that neuro area, or the posterior area there, that is critical for the release of oxytocin, which then has an important role in milk ejection. And then though from the pituitary, there's prolactin release, and then leads to the synthesis of the milk. And all of the hormones that can be involved in that, at least the ones we know of, are listed here. So estrogen and progesterone, which are important pregnancy hormones, inhibit milk production. Prolactin and oxytocin are the primary hormones for milk synthesis, which is the prolactin, and milk release, which is the oxytocin, but so many others. And so when you have a mother who is known to have endocrine pathology, looking at this, you can realize then why it can be so difficult for those women to make milk or excrete the milk. And then the breast itself. So in medical school, I think this would have been 1996, 97. We would do these big weeks long of one organ. So I think the heart was 3 weeks, the kidney was 2 weeks. And then I remember that the mammary gland was 15 minutes of class. And at that point in my life, before I knew what I was going to do, I was so excited that the mammary gland was only 15 minutes because that meant I could learn it fast and at least get those answered right on the test. Well, I was still learning in 1996, still learning what Sir Astley Cooper had figured out in 1840. That was what we were taught about breast anatomy. And what Sir Astley Cooper had done in 1840 is he had a cadaver of a woman who was lactating, and he painstakingly went into every duct there on the external area of her breast and secreted a wax into that that then hardened and made this mold of the breast. And you see there, and I remember seeing this picture in medical school of how these areas of the breast were all laid out. This ductal system was all laid out. And this picture is why then moving forward, into the 90s, into the 2000s, when a woman had breast surgery, be it or was having breast surgery, a breast reduction, breast augmentation, biopsies or something related to a mass needing to be removed, they would often be told, we are going to do a very localized procedure, so you'll be able to breastfeed because we're only going to go into one area and these ducts are all separated, so we'll just only affect one area out of many of your breast. Well, what wasn't passed on from Sir Astley Cooper's work was that he laid the breast out, this ductal system, he laid it out like this after painstakingly untwisting all of these areas. So all of these ducts were twisted together, and then he laid it out, which is why when it comes to then these women who've had surgery attempting and working to breastfeed, often they have significant problems with that because it isn't segmented in this way. That was our misunderstanding of what had been done. So instead, in this new age of understanding the breast, we realized that all of these ducts are mixed together. The other thing that I had learned was that we had these lactoferous sinuses. So this would be a sinus that would kind of hold the milk that was being produced, and then it would be released when the infant started suckling. There's no sinus. That there is milk that's in the milk ducts. There you see on the B side is the newer side of our understanding. There's milk in the ducts, but there's not like a big sinus where all the milk sits. It can sit in the ducts, but then during the actual feeding, milk is constantly being synthesized. It is a very immediate, acute process. So of milk synthesis. So that first milk's released, but then there's a very rapid synthesis of more milk right then and there for that infant. But sometimes, unfortunately, it doesn't work that way. And this is the area that I'm working in now, is to figure out what can we do to help every woman be able to secrete her milk, to both synthesize and secrete her milk. So these are some of the risk factors: preterm delivery, receiving steroids in the week prior to delivery, obesity, cesarean section, polycystic ovary syndrome because of all of the hormonal issues. But these are the ones that we see are related to this delay in the secretory phase, the lactogenesis to the secretory phase of breastfeeding. But we're still now, or the work that we're doing is to figure out, do we have that right? Do we really know what we're doing? And so specifically, I want to talk about women with diabetes. And we've been looking at the women with gestational diabetes that are thought to have this delay also in lactogenesis too, but maybe not. And I don't have those results to share yet because it's an ongoing study. But when I came to Connecticut, this was a paper that had really inspired me to study this population. And I realized that Kilm Doty, who is the first author on this publication, was right here in the New Haven area. So she and I have teamed up on a new study of women with diabetes to look at what's related to their breastfeeding goals, as well as their ability to obtain their best, meet their breastfeeding goals. And part of that was based on Kim's work here. If you see, they are women with gestational diabetes. This was a look at the US infant feeding practices study too, a look at that data, where she had almost 200 women with gestational diabetes and 2,800 pregnant women who did not, and they were followed through their birth and to look at infant feeding. And they did not exhibit a delay in lactogenesis 2, so the secretory phase of breastfeeding, but they were less likely to breastfeed. And when you looked at what was related, what was going on with these women, they were less likely to say that it was the best way to feed an infant, to feel that the fathers were supporting it, to feel that the physician was supporting breastfeeding, to talk about it being comfortable, or to have their baby stay with us. Now, with them, excuse me. So because their babies were usually, or often with us because of low blood sugar and other things, that reasons that these infants would need more of an ICU care. But the part of this that really kind of struck home was that they were more likely to say their physicians prefer formula feeding. And this is an area where exploring how we approach moms, especially with a woman who we think may have problems being able to lactate. We see that she's obese, that she has gestational diabetes. Are we thinking, boy, this could be, we know that this is the type of mother that can fall through the cracks and have difficulty achieving her goals, be it either physiology or kind of her confidence, and then also, are we kind of thinking ahead, or are we the doctor there in the hospital taking care of this mother-infant dyad, where we're worried about hypoglycemia, where we're seeing hypoglycemia? Are we really promoting breastfeeding with those dyads in the same way when there's that risk of hypoglycemia? So this is, again, I think really interesting to look at things that we may have assumed were related to physiology, where instead they might be related more to either education of mom or empowering mom with the confidence that she can achieve her goal. So why would we want a mom to achieve a human milk feeding or breastfeeding goal? Before I get into the evidence, I will say that you all know this, there's not a way to randomize moms and babies for mothers to breastfeed or for a baby to receive mother's milk. So these are observational studies. There's a lot of heterogeneity, in how much milk was received and for how long, and if it was exclusive. And then the area that's really been left out of these studies, it's been in there some, but not to the degree that it needs to be, are social determinants of health, and really recognizing that some of these outcomes may be more related to the fact that healthier, higher socioeconomic women, women with better education, women with higher IQ may have been more likely to breastfeed, especially when these studies were done. But the data that we do have shows that for a mother who's breastfeeding, for the women who breastfeed over 12 months cumulative, that means that, she had 3 children and she breastfed each for 5 months, then she would have been 15 months cumulative breastfeeding. If that a mother has achieved that duration of breastfeeding, she has significant decrease in breast cancer, ovarian cancer, type 2 diabetes, and rheumatoid arthritis. And then if she's gone 12 to 23 months, these are other studies showing decreased cardiovascular disease, hypertension, and diabetes. For the infant, you see they've divided this as ever breastfeeding and then the duration of time of breastfeeding, and significant decreases in infection, in autoimmune diseases, in SIDS, and as well as in allergic diseases. And one area I really want to draw your attention to is there at the bottom. So when a mother breastfeeds for 4 to 6 months, that's fantastic, especially in the US, a working mom, the ability to sustain lactation through everything else that a mom has going on. If a mom can make it to 4 months, 5 months, that should be absolutely celebrated. The issue is though that the infant is still going to get more benefit if the mother breastfeeds longer than 6 months. And you see there that even when a mother breastfeeds 4 to 6 months, which is fantastic, compared to an infant who's breastfed greater than or equal to 6 months, those infants who are breastfed for 4 to 6 months are going to have almost 2 times as much recurrent otitis media and a 4.27 increased risk of lower respiratory tract infection. So there's benefits to the duration to sustaining breastfeeding. For the preterm infant, I'm going to show you some forest plots from a wonderful meta-analysis done by Miller et al. That was published in 2018. And they really went through the literature and divided the papers as best as they could into studies that was exclusive human milk or any human milk. You see there, third down. And I'll show you on the next page, even they tried to look at proportions of human milk. So this is looking at necrotizing enterocolitis for preterm babies. And yes, not every study has a positive outcome. A lot of these studies, there was no difference between groups. You see there, because the horizontal lines cross the middle line, which means that there was no difference in the formula fed or the human milk fed group. But when you put all of the papers together into a meta-analysis, it does appear that the data shows that necrotizing enterocolitis is decreased when preterm infants are fed human milk. And then this looks at higher versus lower dose of milk intakes. That above is randomized controlled trials. And you do randomized controlled trials when you're looking more at donor milk rather than mother's milk, of course. And so donor milk was included in these studies, and then the observational studies there. So we do see this benefit of human milk compared to formula in decreasing necrotizing enterocolitis for preterm babies. Late onset sepsis, there are some portions there where it does appear to favor human milk, but it is less consistent than necrotizing enterocolitis. But you see there with higher versus lower dose in these observational studies, there did appear to be a decrease in late onset sepsis. Bronchopulmonary dysplasia, we don't see as much of an effect there, but again, did see that in some of the observational studies. And the area that has really appeared most recently is ROP. So when in the early 2000s, when I was a fellow, I knew a fellow who was looking at the Neonatal Research Network data to see if there was a relationship between human milk dose and ROP, and it really wasn't, she wasn't able to see it in that data. But as more and more studies have been done, does appear that there is a decrease in severe ROP specifically. You see there the relative risk there of 0.23, so about a 67% decrease with the intake of human milk versus formula. What about neurodevelopment? And of course, I'm talking to Dr. Georgiev and others of you there who have done incredible work giving us information on human development, or neurodevelopment, excuse me, of the human infant. There was a fair number of studies that had shown that there was a relationship between improved neurodevelopment and human milk intake, mother's milk intake specifically. But then this was published in 2006, really showing that we needed to be careful, that there were so many social determinants of outcome that weren't controlled adequately in these studies. So you see there the difference between breastfed and not breastfed infants with mother's scores, her education, age, the home environment, and such, living in poverty. So really difficult to say that it was the breastfeeding or mother's milk intake, and that it wasn't some of these other components that we know are related to neurodevelopment. I will say though, then this was published in 2015. It is a meta-analysis of 17 studies that included follow-up for 1 to 15 years, and they worked very hard to control for everything they possibly could, and did then see that there was a 3.44 increase in IQ with the intake of mother's milk. So it does appear that even when controlling for all those social determinants, that there is a relationship there. And then for preterm infants, very similar. This was published by Winston Koo, showing that our studies did not control for everything that they should have when people looked at or at preterm infants, and whether human milk was associated with neurodevelopmental outcomes. So you see there, none of the studies had neurodevelopment as a primary outcome of the original study. These studies were done for other reasons, and then they chose to follow neurodevelopment in these cohorts. A lot of heterogeneity, really minimal look at social class or socioeconomic status in this population, or maternal intelligence. And these studies were done all over the world, which I think is fascinating that we have such a global look. And they did all show an association between intake of mother's milk and a positive association with neurodevelopment. So you see there, you look at age of evaluation, it went from 30 months to adolescence, but over there in outcomes, for every 10 ml per kilo per day increase in breast milk, there was an improvement in some of the neurodevelopmental scores. Breastfeeding group, again, had higher processing scores, lower risk for reduction, or lower risk for lower scores, and over and over again, seeing these associations. So again, we absolutely need to do these studies with a better inclusion of other determinants of neurodevelopment. But there appears to be kind of consistently this relationship seen between intake of mother's milk and neurodevelopmental outcomes. But again, so much, as I just said, so much goes into that: the psychosocial factors, the genetics, the maternal-child relationship when the mother is providing her milk, and all of these really need to be incorporated into future studies. And so that's what we're kind of that's what we are working on. We're working on looking at the cultural and the social parts of breastfeeding, so we can have a better understanding of those, and then a better understanding also, or a better ability to adjust appropriately in the outcome studies. And specifically, my work though is looking at these disparities and in the maternal infant health, but then also in milk production. So the Baby Friendly Hospital Initiative is a worldwide initiative to provide consistent education and support for breastfeeding prenatally and then also in the hospital. And it is associated with better breastfeeding outcomes. So if you look at this meta-analysis that was performed looking at ways that health systems can intervene to improve breastfeeding outcomes, the baby-friendly support is there is a significant increase in early initiation of breastfeeding and exclusive breastfeeding for 0 to 5 months. Not so much for the 12 to 23 months, that's not significant, but there is more of a significant relationship for any breastfeeding. I think that's up to 6 months. So it does appear to be an evidence-based method to improve breastfeeding outcomes. We realized a few years ago, this work was done by then PhD student Allison Munn. She looked into the baby-friendly research that had been done and realized that nobody had looked at baby-friendly in a diverse US population. So the areas of lacking data in baby-friendly initiative studies were racial and ethnic minorities, lower education, and lower income areas, especially in southeastern US, where we were at that time. And also we needed more information on infant health outcomes, not just breastfeeding outcomes, and then the late preterm or other at-risk infants specifically also. So Allison moved forward from that work. Allison is in Florence, South Carolina. Florence, South Carolina is right along the 95 corridor, so I-95, the interstate goes through, and it's been called the cradle of shame, this area, because of the infant mortality rate there in the Florence area and all along that I-95 corridor is the same as some third world rates. So very high infant mortality there where Allison's working. And so we went into one of the main birthing hospitals there in the Florence area, and they were working to become baby friendly, which was a big deal for this southeastern hospital to be considering this. And they did not think that their moms would be open to all of the 10 steps of baby friendly. So instead they said, let's let mothers choose. Let's let mothers decide if they want to participate or not. So Allison said, well, let's look at which mothers then choose to participate. And what we found is what you would expect, that the mothers who chose to participate in greater than 5 steps were more likely to be white. They were more likely to be married, more likely to have a partner involved, have private insurance, live in urban areas, be employed, have higher education, all of the things that we expected to see. Allison did the work, and that is what we saw. And then we wanted to specifically, though, look at the Black women, the African American women, and get information about their experience with the baby friendly process and their choices to either participate in these steps or to not participate in these steps, because no one had asked these mothers in a research setting, had asked, what's going on, what are you thinking, what is what is part of your decision making. So we asked those questions, and Allison found, when she quoted their answers, that there were interpersonal mother-infant dyad questions. So mother was thinking about infant health. She was thinking about family support. So was she going to have support at home? And then as well as worried that her infant was going to be hungry. So that relationship between mother and infant. There were interpersonal provider relationships. So this is coming from us as a hospital system. Are we giving the prenatal breastfeeding education? Are the lactation consultants involved? And then the overwhelming hospital organization systems effects too. Were we setting up the right services, such as access to breastfeeding support at discharge? Were we setting up the right services for these moms at home? And just real quick, but because I think that it's just powerful to hear from this population that has not had a voice in research development and research conduction, to hear from a few of these moms. So one said, when I got the skin to skin contact with her, it made me feel more like, okay, I'm ready for this, and it's a new beginning. I feel like it might help some women out, because it's not uncommon for women to feel the way I felt during my pregnancy. I felt that if they, which is other mothers, did have this skin to skin with their infants, that maybe it might change their perspective like it changed mine about having another child. Another mom mentioned, I had lactation coming the next day. She showed me how to do this, and that was it. Apologize that I've got the my video. Let me move that over. Sorry, I couldn't read with the Zoom. She showed me what to do. I knew what I was doing from then on. With support from the WIC office, they were ecstatic. They were happy. Passing that pump over. They do rental pumps. They give you supplies. I said, I'm going to try to breastfeed. I'll be back tomorrow. They mentor. They try to get you at least breastfed for 2 weeks before you decide to get a pump. So mom really describing her relationship there with WIC. Another, I think that just with it not working at the hospital where I had access to people to really teach me, just made me not want to keep trying, because I knew when I was coming home and I was on my own. So I just decided just to let my dream go, pretty much, and just deal with what it is. I have to bottle feed, he has to eat. And the last mom, the supply, that's the only thing. Once my chest did get hard, I'm like, okay, then I got the pump and was like, yay, I've got breast milk. Oh my gosh, I'm like a cow. Look at me. The fact that I can actually feed my child. So really, again, letting these mothers speak to show their experience, to show their concerns, as well as what factors were there to facilitate their ability to fulfill their dreams. And as Allison went through this data, we definitely saw racial disparities, but also rurality. So mothers that were in the rural areas felt like they weren't going to have services, so why even try? As well as even within the African American population, yes, there's differences in educational levels there, but it wasn't just education. There still was a racial difference that persisted even when you looked at education. And then the description of the factors to facilitate mothers' desire to breastfeed, as well as the breastfeeding barriers, which were specifically the lack of breastfeeding education and lack of access to equipment and services. We then left Florence and moved to Charleston, which was considered a more, an area more open to breastfeeding. So the hospitals in Charleston were all moving forward with the 10 steps and becoming baby friendly. It's kind of a competition in town to see who could become baby friendly first. And then of course, one hospital said, you know what? We don't need baby friendly, so we're not going to enter the competition. It really got into marketing and all. It's quite interesting. But at the hospital there, we were the academic hospital where we saw the most racial diversity. We said we're going to do this, and we really want to help our mothers, our Black mothers who have historically not breastfed, at least receive the prenatal education, the same prenatal education. They deserve to make an educated decision. And so we really pushed that prenatal education when we're very excited that we saw a 17% increase post being baby friendly. So you see there the increased likelihood of all mothers breastfeeding, at least initiating breastfeeding in the hospital was 1.17, so a 17% increase. Our Black mothers was even higher. We went from 52% to 66%, which we really celebrated, and saw an increase also in our non-Black mothers. But you can see there we had significant racial disparity before baby friendly that still, the gap we thought was narrowing, but was still quite significant there. What we concerned us, and this came from a Black OBGYN resident who said, Dr. Taylor, I hear what you're saying, that things are getting better, but I still don't think, I think we're still missing really reaching our Black moms. And she was right. So Dr. Hemingway and I did this study together, and it's now been submitted. And what we found was that even though the Black women were increasing in their initiation of breastfeeding, and it was an increase greater than we saw for our non-Black mothers, if you looked at the first 2 to 3 days, so just these were healthy babies, they weren't in the NICU, this was our well baby area, that the Black mothers were 2.4 times less likely to sustain breastfeeding. So we looked at all the women who started breastfeeding, and 2.4 times more likely for a Black mother to not be giving her milk on the day of discharge, on that second or third day. So we still had a significant disparity in mothers receiving the in-hospital support needed to sustain their intent to breastfeed. We'll move in now, though, because this also affects the preterm infant, and still dealing with racial disparities in this population too, as well as other reasons that it can be difficult to give mothers milk. So this was a study I did. First, this was my K-23, so my career development study was on vitamin D. And I saw these moms at hospital discharge, and then I would see them again and their infants 2 to 4 weeks later, and got to know these families. Your first big study you get really close with the subjects because you're involved in working with them on a regular basis through the study. So I saw them at hospital discharge, and 58% of the moms were providing their milk. And then 2 to 4 weeks later, so many of them, 67, or I should say 23% of those women who were providing their milk at discharge had already stopped providing their milk. I was like, what is happening? It's only been 2 to 4 weeks. And they really described how difficult it was to continue to pump and to breastfeed, or to put the milk in the bottle and do this every 3 hours with a new preterm infant at home, just overwhelming for them. And so we designed a study called Please for Preterm Infants, promoting lactation education, access, and support efforts for preterm infants. And in the study, we had thought at first we were going to have the moms come back to the academic hospital, but we covered an 8-county region. Some of these mothers would have had to drive 2 hours to come back to see us. That's not very conducive to supporting breastfeeding. So we decided instead that we would educate nurses in primary care clinics throughout this 8-county region. We'd educate nurses to provide lactation support. So we did 10 hours of training with these nurses, and we were available for any questions that might arise. We made sure these moms had an electric breast pump through the whole study, as well as they went home with a scale to help them do test weighs to see if if the mother was breastfeeding, she could breastfeed her baby, or weigh her baby, breastfeed, weigh the baby again to kind of estimate how much the baby had taken. Or a mother could just say, I want to weigh my baby every day. We found that this might empower mothers to say, okay, my baby's growing, my milk, my milk is enough. I can continue to give my milk. And you can see here, these were the different practices. We had intervention practices, 7 intervention practices, and then we had 7 control practices. So it was a randomized controlled study. And we matched the practices on diversity of racial ethnic diversity, as well as socioeconomic diversity, and how far they were from our academic center. The infants were all less than 35 weeks, and these were moms who planned to continue expressing their milk post-discharge. We also studied implementation of this through kind of how it was accepted by the pediatric nurses and pediatricians and the mothers who participated in the study. We ended up with 33 in the control practices and 28 in the intervention practices who entered the study. Those who completed the study were 26 and 22, and unfortunately we did lose one infant, sudden unexpected infant death during the course of the study, which of course was very difficult. You see here in green, the only difference in our controls and interventions was employment during pregnancy, and really the racial makeup and the Medicaid, or the kind of socioeconomic marker of Medicaid, was quite high for the study, higher than it is in other studies of this type. So to get to the punchline, when we looked at the intervention, there was no difference in the intervention between mothers providing their milk for 2, 4, or 6 months post-discharge, whether it was an unadjusted model or an adjusted model. There was no difference. Now, we were proud of the rate. So if you look there in the unadjusted model, 38% and 45% of the mothers were providing their milk at 6 months, which was higher than the percentage that we had expected or we'd seen before this study, but there was no difference between groups. So it did actually raise our thoughts. Just having someone care about your lactation, does that make you want to keep giving your milk? The intervention didn't have an effect, but we did see, of course, as you would expect, if a mother was providing her milk at 2 months or at 4 months, then she was likely to keep providing her milk to 6 months. That makes sense. We did not see a difference by maternal education, which we thought was interesting. We completely expected, this is when we put all the data together, I should say, so no longer looking at it through intervention, we did not see that our educated mothers were more likely to give their milk longer. So perhaps we, through this study, participation in the study in general, some of those issues in South Carolina regarding the relationship between education and giving your milk were no longer being seen, perhaps. The thing we did see is we saw a sex difference. So I was presenting this at a conference in Japan, and someone else was presenting from Canada and had presented that in a study that she saw that mothers of girls were more likely to keep giving their milk, and that mothers of boys stopped giving their milk. And I was like, well, I'll just look at my data and see what happens. Well, I saw the same thing, that the proportion of infants sustaining was higher, of female infants was higher than male infants. So this is something that we're going to explore further in further studies. And so you ask, why? Why would there be a sex difference? Well, what as was described in the study in Canada is that mothers have expressed this perception of infants, of their milk not being adequate, more likely for male infants than for female infants. And in our study, this study was all women who had sustained lactation to hospital discharge and planned to keep going. Even though they'd sustained till hospital discharge, these women still described the most likely reason to stop pumping was low milk supply. And then, though, when we talked to the nurse lactation counselors and we queried the physicians, they both described, neither of them described the barrier as low milk supply. They described the barrier as anxiety. And so this is, again, another area of research. Is low milk supply, is it really low milk supply? Is it a perceived low milk supply? And then how does that relate to anxiety and what the providers describe as anxiety? And then moving forward, can mothers feel that way more often about male infants than female infants? So a whole lot to study going forward here. So in summary, breastfeeding is natural, right? It has been something that's been done for centuries and centuries. We wouldn't be here as a race if breastfeeding didn't work. We have not had safe formula for forever. So breastfeeding is natural. It should work. It's an important part of our existence, but it is not natural in our very unnatural world. So we live in a very unnatural world, and we need to accept that and figure out how to breastfeed in 2020. It can look so many different ways nowadays. I love this beautiful picture showing how mothers feed their babies differently, and we just need to embrace that and realize that as we work to get human milk to babies, to realize that it can be given in so many different ways, and then also not to let mothers be a part of the decision. So our job is to empower mothers with the knowledge to develop her educated goal for her lactation, for herself and her infant. We need to empower her with that, let her choose her goal, and then the tough work of making sure we provide the right care to help mother achieve that goal. Just have to say thank you to my great research team, and especially to there at the bottom to acknowledge those in South Carolina who were a part of the Please for Preterm Infant study. And I think that's it. I think we have some time for questions.
Sarah, thank you. That is just outstanding. So when I was on the breastfeeding task force for the AAP, it was really interesting because there wasn't as much science, I think, about lactation as there is now and that you've championed. And you really got the sense that the ends justified the means, in the sense that, you know, breastfeeding is good. We start with that as an ideology, and then we'll kind of see what data we can find. And I think, you know, your talk has shown that you know, this really is driven by science and reality. The question I would have for you is that also true for preemies? So once again, we've kind of moved along with, well, if it's good for the term babies, it must be good for the preemies. That's kind of an ideology. That's an end. You know, how are we doing on the means to actually show that that's true, particularly donor milk versus mom providing her own milk?
Great question. I have about 5 answers to that question. So
Well, I
you
got
know,
about 3 more big questions, so don't.
so the starting with the donor milk. So I was able to just be a part of based on the pre-B project that we had done previously. I think you were were one of the leaders of the NICHD pre-B project, Michael, and that was to look at what questions remained in nutrition for preterm infants, or what were the most important questions. And so I was part of the Academy of Nutrition and Dietetics, and we went through all of the evidence regarding human milk for preterm infants. And we found, yes, that the donor milk plus mother's milk does decrease NAC. The evidence we have available now does show that. But other outcomes, it's less clear, because the types of studies that have been designed really aren't the highest level of research. And even this decrease in NAC is still just kind of a fair recommendation. It's not the strongest recommendation. So there is more work to be done to take human milk science for preterm babies to the same level as other interventions for preterm babies, the same level of evidence. And we do need to be mindful of the social determinants of health. So as you can tell, I'm a big, proponent of human milk, but I want to recognize that there are some weaknesses in the studies. I think that's critical to make sure that we don't go down this path of being champions without saying, but let's also find the evidence and make sure that this is the right path. And I think very much so for the preterm infant post-discharge. So this isn't, if some people are interested in research, this is an area that has been very much ignored. What are the specific post-discharge benefits to human milk for the preterm infant? There's one study that showed that babies who are receiving mother's milk are less likely to have pediatrician visits for upper respiratory symptoms. That's about it. And we assume that the decrease in otitis, that the decrease in diabetes and autoimmune disease would be the same for the preterm infants, but that's an assumption. Most of those studies were direct feeding at the breast, where a lot of our preemies are being bottle fed. And that's a whole nother area of research when you're feeding at the breast, kind of the mechanics of the mouth or something to do with the connection between mother and infant. Is that what is of benefit? Some people have said so for lung disease, that it's the way the baby's breathing at the breast differently than with a bottle. So is it the milk, the composition of the milk, or some of the benefits actually direct breastfeeding, which is less likely in our preterm infants? And these are just studies that need to be done. So we'll really know.
Let me summarize a couple of the questions that have come in through the Q&A. Common question, with milk donated to milk banks or milk that moms freeze for use later, does defrosting or unfreezing them significantly impact the nutrients? And we know that it does. Can you talk about which ones are specifically different between frozen and unfrozen versus fresh?
Yeah, yeah. So yeah, great question. There are definitely enzymes and cells. You know, cells are going to die in that process, and enzymes are going to be inactivated. But there are a lot of components that are maintained. So the immunoglobulins are maintained. Lactoferrin is maintained. There are quite a few components that are maintained with freezing. One area when we talk about the nutrition of it, the macronutrients, a lot of the fat loss is maybe less about the freezing and more about the containers. So every time you move milk from a plastic container to another plastic container, the fat loves to sit on that plastic. And so you are losing fat every time. When you put it through a tube going to the infant, you're losing fat. And so that is something that there's research being done to figure out what we can do to minimize fat loss. And I think that's one reason that donor milk definitely has lower fat content. Is some of it's the pasteurization and the loss of lipase, but some of it's just the fat that's lost along the way.
By the way, we have a big CMV research group here with a real interest in asymptomatic transmission in human milk. Now, at Yale, are you monitoring or testing breast milk for CMV and
Oh,
preemies, or taking steps to decrease
sure.
CMV transmission?
Yeah, so that's a hot topic. It's my least favorite topic because I really don't
Don't tell
understand.
Dr. Price not to ask that question.
It is it is really I there's so much we don't know about the transmission. You know, it'd be so much easier if we knew there was a specific viral load. That if there was a, you know, I guess a linear relationship between viral load and effects on the infants. I can't find anything that is consistent, and where different studies, so many times the different studies show different results. So it's really hard to find what is that relationship between the viral load and the effect on the infant. So at this point, and you know, Dr. Ravi Patel had a very interesting paper that came out regarding the CMV and risk for necrotizing enterocolitis, and I emailed him because I wanted to know, when was that CMV test done? How did that relate to the development of neck? You know, let's get some real numbers here. And he didn't have those. So there's so much we still don't know about that potential relationship. You know, there's an association there. Whether, you know, the causality of that has yet to be identified. So CMV, when I think about promotion of human milk for preterm babies, CMV is my biggest fear, absolutely. And in Europe, it's such a big fear that they pasteurize mother's own milk. But I have issue with that because donor milk that's pasteurized doesn't have the same neurodevelopmental effects seen. And so I'm nervous that pasteurization of mother's own milk could affect long-term development. And so many of the good factors that are, you know, we don't think donor milk that's pasteurized is as protective from neck as mother's own milk. And, you know, it could be that mother's own milk would be okay with pasteurization, but still nervous we're losing some important factors there. So that's, you know, but that's how serious some people take it, is they're pasteurizing mother's own milk. And I think we have to be respectful of that and realize that it's a real concern. But until we have more, and if your group there at Minnesota would like to email me, my email's right here. I'm always searching for more information because I'd love to know, you know, X plus Y equals Z, and I haven't yet found that in the CMV studies.
I bet you get that email. And one final question. So from Lynn Gershon, who heads our complementary and alternative medicine, what about outside of the neonatal period? Any thoughts about the use of bovine or human colostrum for, say, inflammatory bowel disease or other intestinal hypersensitivities?
Yeah, no, that's a wonderful question. I didn't get into it in this talk, but that's a whole nother area of human milk science where either components or the actual human milk could possibly be used to treat other diseases. So um, it's interesting. Some of these components of human milk, when we look at adding them to either the preterm infant population or to other populations, the bovine products in a higher density are very helpful. And a lot of the components of human milk, say, take the milk fat globule membrane, it was destroyed in formula processing. They're starting to add that back or protect it. The bovine milk fat globule to protect that, with the idea that perhaps there are more components of the bovine milk that are beneficial to the infant, and it's not doesn't have to be human. So that's definitely something to explore. I think also that, idea that some of these components, especially those in colostrum, can be given either, from a bovine source or from a human source and be helpful makes perfect sense. The amount of anti-inflammatory action that's in human milk is quite impressive. And so either giving the colostrum or instead just developing, the single products or kind of, three products together for a benefit. It's definitely an exciting area.
Well, we should be respectful of everybody's time here. Thank you so much for doing this. And I hope we can see you next year at the nutrition conference and then as a visiting professor. Thanks, Sarah.
Thank you so much. Really enjoyed it. Bye, everyone.
Bye.
Bye.
Bye.